I'd like to now invite Dr. Namrata Sharma, Madam, with her expertise, and she's our dynamic secretary AOS, and she would enlighten us with Toric IOL implantation in difficult situations.
Thank you, Naga. I would be talking to you about toric IOLs in difficult situations. And aim for toric intraocular lenses and the problems whenever you implant them, especially in difficult situations, could be sometimes assessment of corneal astigmatism, like when you have a corneal opacity, a precise calculation of IOL power, accurate marking is important, proper alignment is important, and achievement of an accurate and stable post-op IOL alignment is required. This is not coming on the screen. AV team? AV team is not attentive at all. So the difficult situation could be subluxated cataract, small pupil, corneal opacity, in extreme of ectasia, and after you have calculated the intraocular lens power and also this kind of a sheet which is available with most manufacturers is given. This is just to highlight a case in which how you have to fine-tune the position when you're doing a toric intraocular lens implantation. And this is a Callisto guided system. Even if you don't have it, you can manually mark it. An important thing is that just before you do irrigation aspiration, your mark should be about 2 degrees away from your intended axis. And then after doing the hydration, one can slowly nudge the lens into the position so that it completely aligns with the marks which are present on the Callisto. Now, sometimes you can have a torn capsulorhexis in the proximal part. In this case, again, the toric intraocular lens was planned, but notice that on the proximal part, there is a torn capsulorhexis that is present, and it's like a keyhole rhexis there. Again, because the axis of the keyhole rhexis, which is torn, as well as the axis at which you have to actually align the lens is nearly the same, although it is slightly different, but not exactly same. So it is important that you don't manipulate at that area really too much. So even if it goes off center a little bit, rather than rotating the entire lens to its 360 degrees and coming back here, it is important that you just nudge it a little bit so that you get the correct axis without having to open that keyhole rhexis completely and extending the tear posteriorly. Then in small pupil also, it's always a challenge to do a capsulorhexis and to do a toric intraocular lens implantation. Again, one must do rhexis as much as the pupil allows you, and it should be a circular rhexis. Nuclear emulsification, irrigation, aspiration, of course, is being done in this case, and the challenge would be an intraocular lens implantation. But as you implant the lens, you can also see at what axis it is going. And then, at least from one edge, one can always use a Sinskey hook to see at what level these markings are. Here you can see as the irrigation aspiration is being used, the pupil slightly dilates, and then you know that it is the correct axis. Now, again, at times, in cases of small pupil toric intraocular lens implantation, this is a hard cataract. So if it's a hard cataract, it may not be very easy to do a small pupil phaco and then implant the intraocular lens, which is toric. So it is best to put the nylon hooks there and then subsequently do an intraocular lens implantation. And in such cases, again, one can place the marks along the axis, which is being shown by the Callisto here again. And then this is followed by the hydration. Now, in cases of subluxated cataracts also, sometimes it can be difficult to put a toric intraocular lens. In this case, subluxation was in fact detected on the table itself, and it was a subtle, small subluxation. So an CTR is being implanted, followed by irrigation and aspiration. Of course, this can become a little tricky because the cortical fibers, they get trapped in the CTR ring. And then this is again followed by the placement of the lens. Again, important thing is that sometimes because from the area of the subluxation, the air bubble can go at the back. Important thing is that you align the lens in the correct direction. And as you hydrate the wound and as you end the surgery, this bubble should be out. Now, in cases of pellucid marginal degeneration or ectasia such as this, which is more in the periphery and sparing almost the central part, one can use customized toric lenses as was used in this case. And after doing this surgery, this is the customized toric intraocular lens implantation which is being done. And these cases do well, especially the pellucid marginal degeneration, because the center part doesn't get affected as much as the periphery does. So again, in such cases, if you are planning not to do a corneal transplantation procedure and the astigmatism does have some amount of, as seen on the corneal topography map, some amount of astigmatism is there which is regular. Always these cases will have some amount of irregular astigmatism as well. But if there's substantial amount of astigmatism which is regular, then one can do a toric intraocular lens implantation also in these cases after doing phacoemulsification, irrigation, aspiration, and the intraocular lenses, toric intraocular lenses can be implanted in these cases in the axis, which is again as shown by the callisto. Now again, post-DALCs, it can be a little tricky, and again the prerequisite is the same, that there should be some amount of regular astigmatism that is present. We've recently analyzed our cases post-DALC cataracts, and we found that as compared to the conventional cases, these do tend to have a lot more rotation, and this is possibly related to the fact that these DALCs have been done most often in the keratoconic cases, and also to the fact that they do have deep anterior chambers. Now this is just to show the toric post-op CPs of some of the cases which were, some of them which were small pupils, some of them which were bang on, and this should be the eye trace endpoint. And this was a toric IOL in a poorly dilating pupil with a post-op eye trace. This was in a subluxated lens with the aberrations which have come down markedly in the post-op period. So to conclude, toric IOL implantation is possible in selected difficult situations like extended rexes, small pupil with aids like nylon hooks, mild subluxation with aids like CTR, and ectasias, and even post-keratoplasty, but the central 3 mm should have a fairly regular astigmatism. And of course, patient counseling is the key, because sometimes you may not be able to actually put in a toric intraocular lens, especially if there is a problem, especially if you have a large posterior capsular tear, then it may not be possible to put it. So thank you very much for your kind attention. So for the keratoconus patient, we actually rely more on the Keynes formula. Of course, in this case, again, the Barrett True K was used, but given a choice, Keynes formula would be a better option to calculate the IOL power as. Sorry? So post-operative, like I said, that in those cases, especially cases with a corneal opacity, of course, it did neutralize some amount of the regular astigmatism that was present, but irregular astigmatism is something that we cannot address by this.